The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Gary Schwartz. Welcome to the Academy's webinar on House Calls, Evaluation and Management Codes, Part B Coverage and Documentation. Joining us on the call today is Dr. Lawrence Clark, Medicare's Medical Director for the states of New York, Connecticut, and the New England states. Our relationship with Dr. Clark began about 4 years ago around coverage and medical record review and payment issues in New York and Connecticut, and we've had the opportunity to develop the relationship since then. So we're pleased that he's joining us on the call today, and he may be able to provide us with some comments and observations at the end of the webinar. So thank you for joining us, Dr. Clark. The webinar objectives. To provide you the background for Medicare's medical necessity, requirements for Part B service and documentation, to describe the national coverage determinations and local coverage determinations, criteria, to provide the basics of evaluation and management documentation and code selection, briefly mention compliance plan requirements, and we'll go into more detail in an August webinar, reference resources, on this topic and related coverage topics, including the new revised compendium, I should say, of home care medicine services and compendium of federal regulations, Medicare Part B coverage, payment, and compliance that's available, and then leave some time for questions. As mentioned, the Academy has a publication that much of today's discussion, the reference material is included in this material. This compendium is available for purchase now. They're at member price, and then there's a webinar attendee discount available for 2 weeks, and we would encourage you to make use of that opportunity to obtain this valuable background information and compendium of coverage and payment information about your services. So why documentation overview? These services are the majority of your services and revenue. Medicare and private fee-for-service payments requires this documentation. The coverage and payment for new services, such as the complex chronic care management services, will require auditable medical record documentation. And the transition to new payment models, while it will vary by market, will also require documentation of service, care coordination activities, processes, and patient condition. So the basics of Medicare's medical necessity requirements comes out of the Social Security Act, and that's referenced on the left-hand side of the screen here. And while it's written in the negative, the takeaway is that Medicare pays for services that are reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. And this is one of the reasons that the coverage of preventive services and screening is a more recent development, because Medicare's coverage comes out of the historic insurance model of paying for acute injury or illness, etc. And then there's been more recent further definition of medical necessity and coverage for as a Medicare medical benefit as an outcome better than customary treatment. The service has added value, meaning it's cost effective compared to other treatment. Clinical trials required to provide scientific evidence, etc. On the right-hand side, you have private health plans definition. This comes out of national settlements with health plans that were the results of lawsuits between organized medicine and health plans in past years, and provide some of the definitional background of medical necessity. You may also see this language in your contracts with health plans as well. To further define medical necessity, Medicare by statute has the opportunity to provide what's called national coverage determinations, beyond the items that are reasonable and necessary for the diagnosis or treatment of an illness or injury, and that are provided within the scope of a defined and expressed Medicare benefit category. This slide describes that framework of an evidence-based process with opportunities for public participation, and then CMS may supplement its research by outside consultation. And then in the absence of a national coverage policy, an item or service may be covered at the discretion of review material and Medicare's coverage. We do not see any posted national coverage determinations for your home care medicine evaluation and management services. In terms of the local coverage determinations, these are decisions by the carriers whether to cover a particular service or on a carrier-wide basis, again in accordance with the medical necessity language of the Social Security Act that we just saw. And that determination. And the site for the specifics of how that's accomplished are provided here. And then the details of the development of the LCDs are provided here, and it gets into a more detailed basis of the evidence basis and the medical community consensus of expert medical opinion, et cetera. And then at the bottom, that a services item or item is considered to be reasonable and necessary if it's safe and effective, appropriate given the duration and frequency for the service, accepted standards of medical practice for the diagnosis or treatment of the patient's condition or improve the function of a malformed body member, and then the specifics of service there. At this point in time, we see that there are two posted LCDs, and we'll discuss those as we talk about Medicare's requirements for house calls. If there's a reason that you believe that a service may not be covered, well, we're going to go back into the coverage of your house call services and the documentation. Do want to bring to everyone's attention the advanced beneficiary notices, so that if you have reason to believe that a coverage service, that there's a written benefit category, may not be covered in a given circumstance, and yet believe that is the appropriate medical course of action for the beneficiary, then you want to make use of the advanced beneficiary notice before rendering that service to the patient. And the beneficiary should be educated about the benefits and risks of the item of service. And then if you don't provide that service, then you can't shift the financial responsibility to the beneficiary. Participating providers, you still have to submit that advanced beneficiary notice to Medicare. And then if Medicare denies the service, you then can collect from the beneficiary the full charge if Medicare denies a claim. And this essentially provides a beneficiary with financial informed consent that you believe that Medicare may not pay for an item or service, and that Medicare usually covers the item or service, but in this particular situation or use, they may not cover in this situation. But again, that with your discussion with the patient, it is the agreed upon course of treatment. One advanced beneficiary notice may cover an entire extended course of treatment for the year, and then you'd want to maintain that documentation with the medical record for the 5 years. The form itself and the discussion, detailed discussion of its use and completion is referenced here in the citation through Medicare Learning Network materials and then through the carrier instructions. This is also covered in the compendium referenced earlier. So Medicare's Part B coverage of house calls. The medical necessity, the visit in lieu of an office visit. Again, this is going to be for each encounter. You want to provide that documentation. The medically necessary visits are covered and paid under the fee schedule, again, when provided to the beneficiaries and private residents. Those residents are considered both the homes and as we know, the assisted living facilities or domiciliary facilities. Provided when provided in the private residence, and of course they're there with your presence. This again here is written in the negative, that Medicare does not require house call beneficiaries, the patients you render services to be homebound as defined under Medicare Part A for home health agencies. But the medical record must document the medical necessity of the home visit made in lieu of an office or outpatient visit. And then the next point goes into the coverage when there's a relaxation of the incident to requirements in underserved areas. And generally speaking, the incident to opportunity does not exist for house calls. As mentioned, there are two posted LCDs, or local carrier determinations. These are with Wisconsin Physician Services and First Coast Service Options. Collectively, they cover 9 states, Puerto Rico and the Virgin Islands. These states are Iowa, Kansas, Missouri, Nebraska, Indiana, Michigan, and Florida. And the reference to provide some insight as to what those particular carriers look at in terms of documentation and the support of the medical necessity for the coverage and payment of your services, and also because they're instructive and helpful where payment systems are moving to. So so I'm going to go over these, and again I've put the main points from the two LCDs together. So the first slide really describes the sort of the why and when, again, the documentation of the medical necessity of the home visit, and again, in lieu of an office or outpatient visit, and in the chief complaint or history of present illness, what is the reason why you are seeing the patient in their residence rather than the beneficiary's ability and really documentation of their inability to easily or without stress to get to an office setting. The service must be of equal quality as if it was performed in the office. The frequency should be consistent with the frequency of services for that condition in any other setting if the beneficiary was seen in an office setting. The service can't be for the convenience of the physician or qualified nurse practitioner or physician assistant, and I don't think that we would see this as the situation for house calls. And then the level of documentation, given of how house calls have been evaluated and paid by Medicare, is described to be as at the level as high as an office visit, at least as well documented. The next set of requirements from these LCDs that you be the provider of record and responsible for managing the entire disease process addressed in the visit, and that medical services provided are ordered or personally performed by you. Services for others for the same diagnosis would be considered not medically necessary. So again, this emphasizes the point of establishing your primary care provider relationship with the beneficiary and managing their care and being aware of specialists and other others who are providing service to the beneficiary. And that at the onset of care, that the services provided to a beneficiary for the first time are either requested by the beneficiary, his or her delegate, or by another Medicare provider managing the beneficiary's care. And again, the issue addressed here is that of really, I guess, patient solicitation of going through facilities and establishing a relationship that way, rather than the patient requesting the relationship for your services, or someone speaking on their behalf. Again, in terms of logistics, scheduling, and relationships with home health agencies, the next set of discussion points here from the LCDs is that in the assisted living facility environment, for example, that each visit must stand on its own. There is no prohibition about seeing multiple beneficiaries on the same day. And again, that needs to occur for the efficiency and the sustainability of your practices. However, each visit must stand on its own and have the medical necessity documented. And that you have an ongoing relationship for follow-up visits for you or a member of your practice. Services rendered also on the days when home health agencies there would be non-duplicative. You want to assure that there's reasons that your services are there that are outside the realm of why the home health agency is providing service, and teaching or education, training of home health agency personnel, et cetera, supervision is not considered adequate and justification for a house call. And where they would think that others, again, there needs to be the medical necessity that goes beyond the CPO services that you're rendering other services to that beneficiary. In terms of wound care, there are special requirements. Again, there needs to be differentiation from those services that are covered under the home health agency benefits, and that debridement and wound care would be, where they are differentiated, would be defined and described under the appropriate CPT codes. Similarly, that if the administration of a drug or biological is the sole reason, that does not support the reason for a house call. Again, it has to meet the requirements of medical necessity and have the evaluation and management services supported. Diagnostic services, again, have to be medically necessary, and for each of the services ordered, that has to be documented as to why those services are medically necessary in the chart. And again, as mentioned, again, generally speaking, there is not the incident to opportunity, because that requires direct supervision of where someone in your practice other than yourself would be sent out, and then you'd be able to submit a claim for professional services for that beneficiary, because that nexus of supervision is not met in the environment, and there wouldn't really be the requirement for yourself and another professional to be in the patient's residence at the same time. So why is it important to, again, establish that primary care provider relationship? We saw it emphasized in the LCDs from the two carriers. You do want to become the primary care provider of record for fee-for-service payment, again, both with Medicare and private health plans. CMS is developing standards, and they're expected to be discussed in the Medicare fee schedule proposed rule for that's coming out over the next few weeks or within the next month, and that will include coverage of chronic care management services effective 2015, but there will be certain standards for practice and providers to meet in order to be eligible to be paid for those services. The types of patients envisioned are the types of patients that are your house call patients. and they will look for that primary care provider relationship, and will only be paying one provider for these chronic care management services, similar to the transition care management services. That relationship is also important for ACO patient attribution and private health plan development of patient-centered medical home contracts. Also, the relationship, of course, is important for the shared savings and global payments models where we're heading. So, where are you in relationship to the patient and other providers? Another reason I'm emphasizing this, at the recent annual meeting, there were the breakout sessions in the morning, and at our practice management sessions, we went around and kind of queried those in attendance whether they understood and whether they believed that their patients understood that they were the primary care provider of record, and we did get a range of responses from, let's say, from about 50 to 90 or and close to 100%, but it wasn't always 100%. So again, do want to emphasize the establishment of those relationships. So the basics of evaluation, moving on to the basics of evaluation and management, documentation, and code selection. The CPT manuals, there are two levels of codes. Those known as the CP, all collectively known as HCPCS, but the first level of codes are the CPT codes, and then the second level codes are national codes, or HCPCS, developed by CMS for medical services, equipment, and supplies. You submit services such as cert, recert under those HCPCS codes as well. On the diagnostic side are the International Classification of Diseases. And as we know, that ICD-9 is in effect now through the end of September 2015, and ICD-10 will be effective October of 2015. The CPT manual organization is organized as appears here, and the introduction and guidelines and evaluation and management services are on the front end, and at the back are some clinical examples and vignettes of services. However, there aren't a lot of house call vignettes provided as examples. How to search for a CPT code if you're looking for something that's beyond the evaluation and management services, or even anything specific in the evaluation and management area. It's indexed by procedure or service, organ or other anatomic site, condition, synonym, eponym, or abbreviation. The basics of new versus established patients. Generally, whether the patient you've seen the patient by yourself or your practice within the 3 years. Well, if not, then a new patient. If yes, then an established patient. There is a subspecialty opportunity as well, if within a certain practice. If not within that exact specialty, if the same specialty, then established patient, and then within the specialty, there's again subspecialty opportunities to be considered a new patient. Evaluation and management services are there's 7 aspects, but the top 3 are generally are emphasized, except for time-based documentation and coding, which we'll cover in a moment. And the emphasis, again, as we know, is on the history, examination, and medical decision-making. There's 2 sets of guidelines. They cannot be both used on the same patient, but they can be used on different patients. The 1997 evaluation and management ENM guidelines are generally those used more in practice than the 1995 guidelines. Again, as mentioned, there are the 3 areas: the history, examination, and medical decision making. So for time, we're going to go quickly through these and make some highlights. In the 1997 guidelines, we want to establish the medical necessity and the chief complaint and history of present illness, each encounter with the beneficiary. Yet again, each time, whether you've gone in multiple times that week for an unstable patient, post-discharge, et cetera, or it's a patient that you see perhaps twice a year, or a patient that you may see for reasons every few weeks. Again, each encounter you want to establish that medical necessity up front in the, again, as part of your chief complaint and as part of the patient's chief complaint and history of present illness. These are the criteria on the left-hand side of the history and of the chief complaint, and you see those criteria. And essentially, the more there's a build-up model, the more that these are met, contributes to your needs to be documented, and then contributes to your code selection. In the review of systems, similarly, the more systems that are evaluated, again, contributes toward the build-up in your the history and examination. One of the takeaways is that it should be clinically driven based on the individual circumstances of that encounter, and not done really for the the purposes of driving the code selection, but rather the patient's condition and why you're there should be driving the services you're rendering in those documentations. The past family and social history, again, similarly, the more that contributes to the buildup, and that for an initial house call, it would be expected that each of these, and as part of your assessment and certainly of the home environment, et cetera, that you would be picking up the past medical history, the family history, and social history. In terms of examination, again, focusing on the 1997 guidelines, again, there is the definition by the number of organ systems or body areas reviewed in order to select whether the examination has been problem-focused, detailed, or comprehensive. And you see here the problem-focused, expanded, detailed, or comprehensive. And you see the numbers of organ systems or body areas that need to be evaluated and documented to meet each of those levels. Some takeaways from the physical examination are provided here. And the differences in the detail in which the examined systems are described. Always examining the system relating to the presenting problem and not describing that presenting problem as normal or negative. And normal negatives only to describe the unaffected or asymptomatic organ systems. And again, driven by the clinical circumstances of the encounter, and more systems would not be expected with lower level codes.